Wait, do it. Is this on? Do it.
You're not on the live stream isn't working.
Okay, so it doesn't matter.
Oh, it is?
Okay. Well, yes, you matter, whoever's out there in the darkness. Yeah, thank you so much for joining me. Apologies for being late, but nonetheless, glad to see that people are still here. And so yeah, I'm going to walk you through my thesis work today. And before we begin, I'd just like to acknowledge that the lands that we've carried out our research on are and continue to be the traditional occupied homelands of the Musqueam, Squamish, and Tsleil-Waututh folks. Some of the, wait, should I keep the mask on when I talk? Should I take it off to go into my mouth? Oh, well then. Here's my lower face, everybody. But yes, continue to be the traditional and occupied homelands of the Musqueam, Squamish, and Tsleil-Waututh folks. This language is just to recognize that oftentimes when we do talk about Indigenous folks, we do so in the past tense, and it's important to recognize that when we talk about, reconciliation and resistance, that this work is ongoing, whether they be in the form of barricades, whether they be in the form of political advocacy, that these actions remain, and they're continued, and they're relevant, and oftentimes we need to challenge how we perceive it, and whether or not we just prefer some forms of resistance over others. So yeah, especially in health research, we're not known for being very great. So my title today is on the experiences of queer youth navigating substance use during overlapping public health crises. Just to give you a sense of what the presentation will look like, I will first outline the study setting and the context that my research takes place in. I'll introduce and discuss my positionality. I'll explain the methods, the research epistemologies, the theories, and the approaches to analysis that I'm using, and I'll discuss some of my initial findings and implications of my work. At times, I know that my voice kind of oscillates, so maybe just do if I get a little quiet so I can remember that folks in the back also need to hear me and not just myself in my head. Okay, so what is my work about? I know throughout the course of this year, many of you have probably heard this sentence. It's a sentence that looks familiar, but my thesis work focuses on the experiences of queer youth navigating overlapping public health crises, specifically COVID-19 and the overdose crisis. And for the purpose of this presentation, I will specifically be focusing on how have the COVID-19 pandemic and the overdose crisis shaped SGMY perceptions and experiences of substance use. SGMY stands for sexual and gender minority youth. Throughout the course of this presentation, I'll be specifically using queer, but this is just the language that I use. Queer folks don't generally refer to themselves as SGMY. It's very much in the literature, just as a sort of catch-all to capture particular experiences. So in terms of setting up the setting, for lack of diversity in language, I'd like to give you a sense of, because the data collection took place during a very specific amount of time, namely between November 2020 and I guess August 2021. I'd just like to outline some of the major things that happened during this time, which included in November, those of us at Green probably remember this, that social gatherings outside of the household were banned. So, what is a household at Green College, right? Then that ban was extended throughout the holidays. At the beginning of 2021, we began to see the rollout of the first dose, specifically to priority populations, namely those who are seen healthcare providers, those who are deemed most vulnerable. And then also in March and April, we saw the third wave of the pandemic hit. And by May, we saw an increase in the number of people who were vaccinated with their first dose. And then around this time, BC introduced its multiple step opening up phase. And so that was something that came about as well as we were sort of collecting the data. As I mentioned, this is overlapping public health crises, and so there was also the overdose crisis in BC. As a public health emergency, it's been ongoing since 2016. There have been over 8,000 deaths, and that number continues. And this is largely because of a tainted drug supply, namely with substances that are cut with fentanyl. I think it's also important to talk about, and it's relevant to my work, that in the first 5 months of 2021, 137 youth under the age of 29 passed away from overdose-related deaths. And I think part of the reason why this is important is that in a lot of the literature that we see, and a lot of the sort of political discomfort with addressing issues around youth and substance use, it's important to recognize that youth do use substances, youth do take steps, youth are responsible when they use substances, but unfortunately because of the lack of policy, the lack of support, the barriers to care, that youth are passing away. And I think also as we sort of talk about death, it's important to contextualize this in the fact that there has also been 30 years of community-based work and resistance. against HIV, Hep C, and overdose. And we have organizations specifically in Vancouver, to give the example of the Vancouver Area Network of Drug Users, the Western Aboriginal Harm Reduction Society. So there have been many organizations in the community, both here and across the province, who have been pushing the government, so with safer consumption sites, with better policies, like all of these things, like Insight, this was not something that the government came up with. The community literally had to set those up illegally, and over the course of like the 90s and the 2000s. And it wasn't until, yeah. So I think that's something to realize as well. So who's Rodney? You know, who am I? So I have like a couple little pictures. So my name is Rodney Stehr. My pronouns are he, him, and they, them. I identify as a mixed settler on these lands. My mom is Fijian. She comes from the villages of Nadavanande and Minyingi and Vanuatu in Fiji. There's my grandparents in the top right with me, that little beige baby. My grandfather's Rachipelli, don't worry about the names. You don't have to write them down. And my grandmother, Kinisila Faisuva. And then also at the bottom are my grandparents. My dad's quite old, so I never met my white grandparents. That's very nice too. But they're just the gentleman with the top hat and the, I don't know, the weird sort of pagan getup that's going on over there. And that's in, I think, Lithuania or something in 1939. And then there's my father, who's also up there with less hair, in 1951. So after he left Europe. Not a great time. And I guess another, in terms of other things about me, in terms of thinking about positionality, before I was in research, I did not expect to be in research, but lo and behold, here we are. I worked in a lot of drop-in capacities with youth, specifically around sexual health and harm reduction. So across Metro Vancouver, so with the Empowerment Program and YouthCo, HIV AIDS Society, and then also with Friends of Dorothy and Langley and Parents of Dorothy. So I was working with youth and parents and caregivers of queer youth to sort of teach them not to be horrible. So those were some of the things that I've done. And then most recently in the bottom left, right to me, I'm with my research team at the BC Center on Substance Use. And so we still do community work, but we look at it at sort of a different lens. And that really helps inform the work that I do, thinking about the geographical barriers that exist for youth when it comes to accessing care. What is, when we think about like implementation of public health interventions and interventions with like programs and testing, what are the actual barriers for youth when they try to access these spaces? And that was all sort of like a part of who I am as a mess. So in terms of positionality statements, I think, so I did provide like a very vague or very like kind of general biographical sense of who I am, but I think it's also important that oftentimes when we do these things, they can serve as a way to establish our authority, and they can not be as critical as we'd like them to be. In addition, that if we want to work towards positionality statements that are more meaningful, then they have to account for not just the uncomfort that we have in the research that we do, whether it just be me researching other queer youth who are having a hard time, but also thinking about myself within institutions and also a lot of like the political sort of implications of what it means for me as a part of the BC Center on Substance Use. Anyways, that's the next slide. I don't want to get too excited about it. So some of those complexities look like the question of like, am I a part of the community? Are we peers? So when I'm sitting down and interviewing other queer youth, I may be racialized, I may be queer, but I come from a comfortable middle-class background, and I don't use substances that are criminalized. And so like thinking about the ways in which I'm both a part of the communities and not, I think are important things to think about as researchers in qualitative research, thinking about how, we don't want to assume that we're peers, we don't want to assume that we can express or talk about other people's experiences when in fact they can be quite divergent. And then also like aspects of myself that are, I guess not inherently Western. And so discussions about like Vakaturanga, which is a sort of framework that Unesi Nabobo talks about, and this idea of responsibility and reciprocity and what it looks like in terms of, knowledge gathering. So when I work with other youth, what does it mean to think about responsibility in a way that matches up with my framework as someone who's Fijian? What does that mean in terms of the responsibilities that we have to folks that are marginalized, in terms of not just like in the moment and what kind of like therapeutic trust we develop, but also in the long term in terms of you shared these stories, these difficult stories about things that you're going through in your life, and how do we ensure that, these are not just studies that I get to populate in terms of first authorship or somewhere in the middle, and like how does it actually like result in like tangible change in people's health outcomes, and sort of sitting with sometimes the feelings of futility that come with that, and trying to think of other ways. And yeah, as I said, not a practice of self-flagellation, so I'm going to end this section. It's not cute. Nobody really wants to hear, how you're struggling with the work when really it should be action-oriented. And I think, You know what? No. So really, to get to my work, what methods am I using? So I've been using digital diaries, and so they're hosted on UBC's REDCap server, which REDCap is like an online interface for survey data. It's been quite useful. It's also compliant with a lot of provincial and federal-based privacy laws, so it's been a really helpful way. It's also available through the university, so if any of you would like to use REDCap for your own sort of work, it is available through the institution for free, and that's the reason why we selected it. And in order to connect folks with diary entries, because this was done online, we weren't doing like traditional text-based diary approaches, the diary prompts were sent out twice a week by email. Participants had about a week to finish each diary entry, and most participants took around 1 to 2 months to complete the study. So this is like a longitudinal study with multiple points of interaction. And this is just like an example here. So there were 2 sections in the solicited diary entry. The first part was just like a general sort of question that was constant throughout the 6 entries that we sent. And it was just like, how have the last few days been for you? Describe your daily routines. Tell me anything that you came across that brought some joy or laughter, a TikTok, a song, a cat sighting, a snack at the back of the fridge that you forgot about. And what do you miss? And so these were some of the questions that I thought would be really helpful, because for the questions that were mandatory, they were part of the survey. They were quite heavy in terms of just like, what are your experiences with the overdose crisis? And so we thought it would be helpful to have these kind of options here for folks who maybe don't know how to start, so that they don't go straight into being like, yeah. And so we didn't just use the digital diaries by themselves. They were bookended by intake and follow-up remote interviewing that we did over Zoom and over phone. And this was a way that for our 30-minute intake interviews, we were able to introduce people to digital diary methods and sort of get a sense of what their general knowledge was. And then with the follow-up, this provided us an opportunity to expand upon the digital diary entries to get a sense of like, oh, if they're not talking a lot about this aspect, or they mention it very briefly, how can we get a better understanding of this? And so this sort of helped complement the digital diaries in a way that we found quite fruitful. So in terms of framework and data analysis, oh, this is the fun part. So my research epistemology was kind of, oh God, this was a struggle. Lindsay, you were there, and Graham, when I was like trying to figure out like, what's the difference between social constructivism and social constructionism? Because like throughout the literature, sometimes folks use it interchangeably, and they'd be like, this is what the definition of social constructivism is, but it's really, and then it's like cited as social constructionism. But anyways, the definition that I fell upon and that I will hold on to and I will defend to the death of me is the one that I'm going to use by Creswell, which individuals seek to understand the world in which they live by subjective meaning-making through interactions with others and the historical and cultural norms that they are embedded. And then I thought it was also helpful to then complement that with Schwann's sort of approach to social constructivism, which was rejecting essential or natural givens that present social outcomes as inevitable. And this is like really important in public health research, because oftentimes when we talk about health outcomes, when we talk about social determinants of health, it can feel deterministic. And so it's important to have like this kind of theme throughout the research to remind us that when we're saying, especially with the next theory, when I talk about minority stress theory, this idea that like just because as queer folks we face these particular stressors or we have these particular outcomes doesn't necessarily mean that they're inevitable. And that's why I think Hacking's quote here that X need not have existed or need not have to be all that it is. X, or X as it is present, is not determined by the nature of things. It is not inevitable. And so I think it's important and I think very helpful when we look through the diary entries when folks are having rough times to realize like this is not somehow intrinsic to being queer. In fact, this should not even be happening. So in terms of minority stress theory, again, I'm using Meyer's sort of conceptualization of it, where gay people in a heterosexist society, i.e. one that discriminates against those who are not heterosexual, are subject to chronic stress related to their stigmatization. And so when we talk about stress, we can mention stressors looking like internalized homophobia or transphobia, and then also expectations of rejection and discrimination, which is also really important, again, in health research when we think about what prevents us from accessing the care that we would like, what prevents us from feeling safe in communal spaces, in educational spaces, in employment spaces, is this like expectation of, oh, when I'm going to end, I'm going to be treated like X, Y, and Z. And then also experiences of discrimination and violence. And then also when we talk about stigma and we talk about stress, it's important to understand that it has a corrosive influence on health. It's not just like a spurious, and they're like, oh, this happens, and therefore this happens, but like it can have very real impacts on educational attainment, economic resources, social relations, and healthy and coping behavior. But once again, the importance of sort of marrying this with social constructivism is this idea that like, just because this is a possibility or that this is some people's lived experience doesn't necessarily mean that this is the same across the board. So this kind of helps balance it because again, minority stress theory is very helpful but can have its limitations in terms of how we talk about queer experience. And then finally, thematic analysis. And this is just how I'm sort of engaging with the data. I'm using sort of theoretical thematic analysis as it's called by Brown and Clark. And basically, as I go through the data, through the diary entries, through the transcripts, I just look at semantic patterns. As I read through, I say, okay, this individual is talking about risk, or this individual is talking about difficulties with mental health services. And these are sort of the things that I pull out. And this is informed by theoretical and research interests. So by, as I mentioned, the research objective that I shared with you in the beginning, and sort of, it's also an iterative process where I've, been, there are 4 other code books from other projects, and so that all sort of kind of informs how I interact with the data. And it's compatible with social constructivism as it is used to theorize the social cultural context and structural conditions that enable the individual accounts that are provided. There we go. So now my findings. I know you've all been waiting for them. So to give you a sense of who participated in the study, we had 15 participants, and they fell between the age ranges of 18 to 25. The sort of average age was 22, 60% identified as white, 40% identified as Chinese, Korean, South Asian, or Latin. Obviously, there were individuals who identified as mixed. There's still, I think, some area in terms of like how we can better account for those experiences, but right now it's quite limited. And then also about almost half of the participants that we talked to were non-binary, and that was a joy. I think it was because of the poster. I mean, this is making me like a within community joke. I had like a lot of ferns and stuff, and anyways, okay, maybe this goes over your heads, but ask me over dinner and I'll tell you about ferns and queer people. And then 60% identified as bisexual, 53.3% identified as queer. And these strange little decimal points just indicated that individuals had more than one identity because people are what? Non-linear. And then finally, in terms of substance use, mostly folks disclosed using cannabis, alcohol, benzodiazepines, psychedelics, and also cocaine, both throughout the course of their lifetime and also within the last 30 days. So some of the major themes that came up over the course of my sort of analysis included impacts of overlapping public health crises. So in some of the conversations that I had with youth, they talked about how it was harder to use substances safely as a result of COVID-19. And this had to do with a variety of different reasons, including the fact that, a lack of social support. As we know, that, because of public health guidelines that were necessary in order to flatten the curve of the virus has also introduced precarity to employment. Unsafe housing, as you know, for many folks who are stuck at home with sometimes caregivers, roommates, or families that were not necessarily unsafe. That also made things very difficult for folks. And so again, we have these kind of experiences with folks describing difficulties around using substance safety. There was also a part of these conversations, people being worried about their friends and family members who might use or consider using, because as I mentioned, the lack of support systems or the shifting in support systems meant that it was harder for folks as they talked with me to say, I don't know how to reach out to my friend. I don't know how to provide the support. Usually I would be there, I would go with them to the testing site, or we'd be using together, but because of public health guidelines and stuff, we can't use together because we live together in this SRO, and so on and so forth. I think, and then there were also discussions around the emotional impact of loss, whether experienced and anticipated. So in a lot of conversations with the overdose crisis, a lot of youth talked about being concerned about their friends or peers, not only in terms of worrying if they would overdose or pass away, but also the fact many of whom were talking about how they've had this experience in the past. One participant talking about the sort of difficulties of attending a funeral over Facebook. And so these were other things too, kind of balancing the fear of losing friends and also sort of dealing with the trauma and the loss that comes from losing friends as a result of overdose. And we see this example in Victor's diary, where he said, "The overdose crisis means that a lot of people are dying because of drugs. It saddens me and makes me scared of using. I don't want my life to become a statistic in the way of death. The COVID-19 crisis has made the drug supply more toxic, and I'm worried about my friends who continue to use." And of course, we can't talk about the overdose crisis without talking about government response or the lack thereof. And so over the course of the discussions that I had with participants, All 15 of them were able to very clearly describe what the overdose crisis was in terms of their experiences with it or their perceptions of it. And many of them talked about how they felt, despite the increasing numbers of deaths, that the crisis was still not receiving adequate attention. And when we think about, the number that I shared earlier, about like 8,000 deaths and the fact that it's ongoing, this was a source of great frustration, and both, and from myself as well. And then the overdose crisis is not prioritized. There was also discussions around how they felt that the overdose crisis was not prioritized because it was specifically impacting poorer populations, often indigenous and racialized communities who also use substances. And finally, some participants expressed that COVID-19 has only given the public more reason to ignore the overdose crisis. And we see this in Chris's diary entry, where he shares, "The overdose crisis means people are dying for no reason other than negligence from people in power. Why can't it be addressed with the same kind of energy as COVID?" So as we were talking about the overdose crisis and talking about substance use, naturally discussions around support and what those sort of shifts kind of look like for folks came up. And so specifically in the context of virtual care, when folks were talking about the services they were accessing, they talked about how mental health supports were often a deterrent because that shift from in-person to online meant that there was difficulties around building rapport. As many of them talked about, the counselor can't really read my body language and it's weird, or I don't really like talking over the phone with my counselor. And there was also concerns around privacy for many folks who lived at home with family or with partners who may potentially be the source of the problem, that it was very difficult, or they did not want to necessarily access those services at home. However, other folks conversely mentioned that this was a benefit of the shift online, that they were able to call from their own homes. So there was diversity across the sample, because again, people are diverse. Participants who disclosed, there was also some important conversations that were had around accessibility and the complexity around, what implications look like across different populations within the queer community, specifically for folks who are part of the disability community. And so for folks who disclose living with chronic pain, they mentioned the benefits of being able to sort of call in or access virtual appointments, whereas there was also discussions around how the user experience of booking appointments online, i.e. endless phone calls and phone trees and inaccessible website design, introduced new barriers to other individuals who were disabled. And we see a little bit of discussions around ableism with ZK in their follow-up interview here, where they said, when COVID-19 started, a lot of services were halted. And this is something that I guess a lot of people, like a lot of able-bodied people, don't think about. It's just the fact that some people need to see a doctor very frequently, and the need to have things done very frequently in order to even function. And by function, it doesn't mean a regular person, it means not dying. So not being able to access a lot of these things have really impacted a lot of the disability community who already had trouble accessing the stuff otherwise. There were also quite a few discussions of risk, whether it be in terms of, how am I going to decide whether or not I should go with a date on this person in the middle of the third wave of the pandemic? But there were also discussions around how people manage risk in terms of their substance use. This was often framed in two ways. So either proactively, i.e. recognizing that the substances that they were using were more dangerous as a result of border closures, and therefore there would be a higher likelihood of folks overdosing, or other times it would be as a result of or reactively, as we would put, i.e. individuals disclosing recent experiences with overdose and then deciding to shift substances as a result. I think another thing that came up that I think is quite important to think about when we think about risk. It's important to think about race too, naturally. But balancing the need for social connection with the risks of COVID-19, and this came up quite a lot, these feelings of shame around I want to connect with my friends, I want to see them in person, but I'm contributing with public health guidelines, and I feel like shit for doing so. And so this came up quite a lot with these wanting to connect, but feeling like you can't, wanting to go to parties, but then all those sort of things, especially for folks between our particular age range, is kind of a part of being young-ish, or all that jazz. I don't know. I can't remember. It's been a while. And then we see this an example with Sadie in her diary entry, where she says, New Year's Eve was a few days ago. I had some drinks with a friend in the neighborhood I used to frequent when I was drinking heavily pre-COVID. It was the first time I've had that much alcohol in several months, and running into old acquaintances triggered anxiety and shame spirals in the following days. I'm still struggling to find my balance again. It is compounded by the fact that while the conditions I chose to see my friend in were calculated with precautionary measures, I'm reluctant to reach out for support because of fear of being judged for seeing a friend while cases are so high. And finally, another theme that I thought was quite important to share with folks today was the experiences of changes in social connection. And so throughout the course of this presentation, we talked about, not being able to, folks having struggles or difficulties figuring out how they can support their friends with substance use and so forth. And in these discussions of like changes in social connection, folks shared that, because we can't see people in person anymore, we've been moving to Discord, we've been moving to Zoom, we've increased texting and phone calls, and some folks were talking about walks and the importance of distance walks. But in amongst all these discussions, there was some difficulties that were communicated, especially with Zoom, whether it be in classrooms or in drop-in settings or in social contexts. With one youth, I remember we had this conversation about them being really excited to go to a drop-in, but then it was over Zoom, and they said, Rodney, Zoom doesn't have hallways, so it's like really difficult to like make friends, because once the session is over, it's over, whereas like in person, if any of you have ever been to like a drop-in or a community center, you kind of like hang out with the person afterwards, you walk to the bus, you maybe say like, oh, do you like Mitski? And you're just all those sort of little things that kind of like build rapport. And those sort of things didn't exist, and so it was really difficult for folks to find connection in that way. There's also interruptions of routine. For folks who found a lot of importance in terms of, or a lot of their social interaction that came from sports teams and going to the gym, the closure of those facilities and the stopping of those in-person activities impacted their sense of structure and mental health. And for many folks, because there are a lot of like queer sports leagues in Vancouver, for those of you who might not be in the know, that was another way that folks were able to like connect. And so that sort of stopping of that not only impacted people's, I guess, access to exercise, but then also their ability to connect with other queer folks. And so, again, discussions of missing out and birthdays, friends, belonging, and desire. And especially amongst, because we had a few of our younger participants who were recently out, they talked about the desire to connect with other queer folks and the need to sort of feel a part of the community, but not being sure how to. And so that was very difficult in the sense, as I mentioned with that Zoom example previously, how do you connect? You're just out, you want to hang out. And usually you'd go to like a slam poetry thing, or you'd go to like a queer bookshop or something, or roller skating, I don't know. But you can't really do those things. And this was sort of contrasted with some of our older participants who either lived with folks who were queer, or who already had those sort of social support networks available to them, and they were less likely to feel disconnected from their community. I'd like to share again a quotation from Sadie to discuss this. I came out this year, like within the past 12 months, and I came out both to myself and to my family. It's been a lot of time alone in deep reflection. Like during this sort of process, I really want to go out and meet people like me and meet the people in the community who've had similar experiences. But it's also the sense that if you're not tapped into that community already, you wouldn't necessarily know about them. So it's that in itself is incredibly isolating, like not having a queer community around to talk to. So sort of wrap up this presentation to talk about the implications. I would say that some of the initial findings when we talk about social connection, kind of affirm emerging literature about the role of strength and security of social connection, that social connection can play as a protective factor against feelings of disconnection. So as I just provided with those previous examples, the idea that for many older folks, who've had queer friends, who've done the clubbing, who feel kind of salty about those experiences, they're like, I'm good. But in contrast with a lot of folks who are new or have just come down or are really interested in connecting with other folks with similar aspects of their identity, that it's quite difficult, and they often felt isolated as a result. So I think that's something that's really important in terms of emerging implications from my work. I would also say that SGMY's accounts of the pandemic and overdose-related stressors provide us with insight into how overlapping public health crises are impacting youth differently. And this, of course, aligns with what we talked about in terms of minority stress theory, but also just generally thinking about the policy implications of gaps in care and employment around when we see with government response and youth feeling like their lives don't matter, because they use substances, somehow they're invisible, that oftentimes the implications of this is that care falls on youth, their friends, their affected others, and so they're doing that work ensuring that their friends are alive when, And then also oftentimes having to educate the service providers, educating politicians, doing that sort of protest work. And so those are some of the real, I think, implications that are important to think about, that gaps are not just like, oh, we need to do better, but like, while you're doing better, like folks are actually, still actively trying to stay alive. And it's important, that sense of immediacy that is so important. And I think that comes through in a lot of our work because, yeah, it's not great. And then finally, also employment. I think discussions that I've had previously in this presentation around ableism, around accommodations for folks who are part of the disability community. This idea that a lot of the switches that we made as a result of COVID-19 in terms of remote work, in terms of flexibility around like working hours and stuff, have been things that members of the community have been advocating for decades. And it's only recently, as we recall Sadie's quotation, because the pandemic has been impacting able-bodied communities, that these changes have come across. So it's important to think about those too. And there was a lot of worry too about the sort of return to normal and what would it mean that as we progress back to different stages of opening, what that would mean for a lot of communities who are immunocompromised, who were actually quite enjoying connecting with friends remotely, and like what would that mean for their experiences of social connection, of support, and access to care. And yeah, analysis is ongoing. So maybe check in with me in a couple of months and I might have more to share with you. To end with likeness, because this was like a lot, I want to share 2 diary entries that I thought were cute. So first there was Layla, who said, "It was nice to celebrate New Year. I just dressed up and counted down with my friends over video call. I miss my friends and my boyfriend a lot. I will be able to see him on the 10th, so I'm looking forward to that." And then also Victor, who's the personal favorite. "Something I did enjoy recently was getting to connect with some people from the local LGBTQ group. It was nice to be able to talk about some of the experiences I've had and just be true to myself. Also, super exciting news is that my binder got put in the mail today and I get to start binding soon. I literally cannot contain my excitement." So I think that's what I really enjoyed, like those little moments of like queer joy that just like, oh, feed me. Yeah. So I'd like to thank all of the participants, all of the youth who took part in the study. I'd like to thank Dr. Rod Knight, Dr. Daniel Fass, and Dr. Serena Mekpi for all their support and guidance. And the study was funded by a grant from the Canadian Institutes of Health Research, and my research was funded by the Canada Graduate Scholarship Master's Program. These are my references, and this is the final slide. Thank you. Questions, I guess? Yes?
Thanks, Rodney. My question is about, I might have missed this maybe when you were introducing the sort of target demographics we were looking at, but I was wondering how like class positions sort of factored into this, and also if minority stress theory addresses poverty and like economic resources as like part of their theories. Especially with like a health thing, it just seems so kind of clear, right?
Yeah. I wasn't sure. So when we were dreaming up the social demographic questionnaire, I felt really, and it's just me being like transparent, I felt really awkward about asking about like, because sometimes the way that they sort of account for that, they're like, well, what does your annual income look like? And so I would say, yes, class definitely features within minority stress theory because, just the ability to afford care, and we know that a lot of things in terms of mental health and a lot of other sort of care cost money that's not covered. We know that we don't have universal pharmacare. So I think absolutely, like minority stress does account for that, and I think aspects of class was, I think, quite clear across, like, as I was talking with different participants, where some folks were like, yeah, I was just at home, really, my family, on Zoom, and then other folks were like, some folks just quite literally had to discontinue participation in the study because they were just not in a great place. They had to prioritize other things, and naturally the thesis work of some, I'm not bespectacled, but some bow tie wearing master's student was not a priority, even if they felt that sharing their story was important. So I think we can't discuss, as you pointed out, we can't not discuss outcomes without class, because it's so intrinsic, and that's like kind of positionality piece as well, as I mentioned, the idea that like, I may be racialized, I may be, X, Y, and Z, but because, I'm an RA, I have access to extended health, I'm able to access a lot of the services that the participants that I work with are not able to. And so I think that's something that's important to think about in many aspects as well. Yes, Rika? Yeah.
Your research data aligns with that. But I was wondering if there is any other compliance theory in your research field, or if minor stress theory is a dominant or next theory that has a more connection.
I would say the minority stress theory is the theory that I am most familiar with and thus able to like draw on in sort of the period that it took me to put together this presentation, but there are so many other theories. So like, as I was reading, I think there's this quotation here, I think, wait, I don't know, this maybe, anyways, when I talk, actually it would be under implications. Like Parent et al., that particular citation, they talk about like attachment theory, but this is an area that I'm not too familiar with, so I can't necessarily talk on it, but like this idea of social connection, like those are other theories that I could very easily draw on, and I could find, I think there is a lot of discussion around that, and it comes up quite a lot of the data around like, and especially if I want to kind of follow a more strengths-based approach, so things like attachment theory that kind of look at like, social connection and as protective factors, because that's my big discomfort with minority stress theory, and it's why I want to, as I continue to move forward with the different phases of my analysis, is to find theories that kind of focus more, maybe it's like, different critical theories that kind of like highlight the fact that like, queer youth are not being like passively impacted, like they are looking after folks, they're after each other, there are like sort of critical approaches towards the ways in which they're like taking care of each other and also like resisting government, resisting surveillance and all that sort of thing. So I think, I don't know if I answered your question, but hopefully I touched on some of the points that you were interested in hearing from me. Yeah. Oh, yes. Oh my God.
First of all, you gave me talk, and thank you for kicking off the member series, which I'm sure is going to be an excellent series. And yeah, I mean, one entry or one sort of thing that was super interesting to me that was unintuitive and I wouldn't have expected is how like the dominant narrative has a different effect on some of the minority groups. So the COVID epidemic, the pandemic, like, oh, these frat houses are having parties, or these unvaccinated, whatever, careless people are going out and putting everyone at risk. We should shame them into going back inside, right? Like, let's do that. It's in there. That's the dominant narrative, and that is adopted in some ways. But we never think how is mobilizing shame affecting different groups of people differentially. And so I guess the question would be something like, how do you see these sorts of minority groups get left behind, or how these sort of negative byproducts of dominant or majority approaches to addressing these social health problems like COVID?
How do they? Sorry, how do they?
Yeah, so we have like an approach to address COVID, or a bunch of different approaches to address COVID, and we're always thinking about majority groups.
Oh yeah.
So how did minority groups get left behind, or not taken into consideration how they might have differential impacts on the employees?
Absolutely. I think like the examples that I've given around like folks who like identify as part of like the disability community and how they're often left out in terms of just like a lot of the language around like when they talk about accounting for deaths, they're like, okay, X amount of people passed away, but they had underlying health conditions. And so that's like an example of how like, we're focusing mainly on like able-bodied individuals and like, well, nobody who's fully vaccinated and able-bodied is dying. So we're fine, we can open up. But like, this idea that like, smaller marginalized communities who are left out of this kind of dominant narrative, and that's kind of what like ableism is, right? This idea that like, particular bodies should be prioritized because how they operate are seen as normal, and everyone else who kind of deviates from that should be either changed or like intervened upon. And so like a lot of that implications are very much like oftentimes a case of like life or death. And when you talk about shame, like, in public health, it's kind of funny sometimes. There's literature around like shame is not an effective public health intervention because it doesn't work. And oftentimes it places already marginalized communities when we look at like discussions around HIV and how, like, oh, you should be using a condom, you should be doing X, Y, and Z. But like, if you're navigating multiple barriers in terms of, I don't have access to consistent housing, or, I'm in a relationship that doesn't always allow me to use a condom, like, it doesn't take into consideration the fact that there are power dynamics, the fact that, we're not able to do, like, the resources can exist, but that doesn't necessarily mean that we're able to access them either because of geographic differences, either because of systematic racism, either because of ableism, and all those other sort of things. Is that helpful? Okay, thank you. Oh, I don't know who gets seniority, Mark or Azar. Azar? Oh, okay.
Fascinating. Thank you very much. I'm just kicking off my listening. I have a couple of quick questions. One was, what do you see as potentially the afterlife of this little, this project? You've dealt with 15 respondents now, and you experimented with the theory, and you sort of see this going anywhere after this. What would you like to have? So that's one question. The other question was, I was curious about your choice of method. You were talking about semantic analysis really of text, and using social constructionism as a lens through which to look at text. And since your analysis was, correct me if I'm wrong, almost principally of the text, you didn't get to really meet your respondents.
Well, I did talk to them.
Oh, you did?
Yeah, sorry. That's what I meant bookended. So I had a phone call at the beginning in an intake interview where I was like, this is what it's going to look like to walk through the diary entry. And then they did the entry, and then after there was a follow-up interview where I then said like, oh, here you said, oh, I don't like John Horgan. What was that about?
So given my own sort of training in anthropology, I was curious as to whether your respondents had expectations of you beyond the brother.
Yeah. Okay. So I'll answer both of your questions. In terms of the afterlife, that like definitely haunts me, and it's good whenever we think about knowledge translation that we sort of plan that at the beginning of the process. And so some of the ways that I've kind of hoped to integrate that is that we have recruited some of the participants from the study, because with the research team that I'm part of, we have a youth advisory committee. And so I've recruited a participant from there. I mean, that's like a very really truly, is there even a bar? But that was one way. So we recruited him, or them, is an individual of no particular gender, and kind of engaged with them in terms of showing this is what the work that we do on this team looks like, and kind of building the capacity there, and then potentially involving them with a lot of future KT work. So I try to be very annoying with a lot of the sort of research products that we do, in the sense that I will connect to different groups and nonprofits and be like, hi, remember me? I used to work with you. I have this presentation. Or we get invited to grand rounds, and so that's when this is again, it is a way that I kind of go to sleep at night, is the sense that we hope to not only develop manuscripts from this, but also just plain language summaries that I could then circulate to a lot of nonprofits that work with queer youth and a lot of other sort of services. And because our research team is a part of the BC Center on Substance Use, we have access to different health authorities. So just recently I did a presentation with Interior Health around queer identity and substance use. So there are a lot of, yeah, so we'll contribute to policy, not in the direct sort of way that I would like, but fortunately, I know a couple of counselors, so I kind of be like, hey, remember me? I door knocked in the rain for you. Here's a study that you should probably read. But it's not ideal or direct, because, I mean, for those of us who are we're all a part of academia, we know how long it can take, and it can take forever. So I think when I think about the afterlife, I think about how many ways can I just be annoying in a way that's short term, while I still have funding and while I'm still a part of the team, to use those resources to kind of really hammer in the messages, even if it's just maybe don't be racist, those kind of things. And then your second question, oh my God, your second question around...
Whether your respondents had expectations of you
beyond. Yeah. I'd say, and this always makes me a little sad, but oftentimes when they communicated, they were just I don't know if anything will come of this. I just thank you for the opportunity to talk about this. So the expectations is not always clear, for many folks, I don't know how to word this, it was not always clearly demarcated by them, and usually we would have conversations about it, but they would say, I'm not sure how to answer it. It just makes me really sad. Oftentimes the folks were just I'm just glad to be able to talk to this. I know with one participant, they're often when I talk about these things to my service providers, they don't really pay that kind of attention to me. Or when we take part in like larger like surveys where we just kind of fill out over like 30 or 40 minutes about like our health outcomes, that it feels very impersonal. So they don't often like explain those kind of things, but really that's not for them to voice. That's really my responsibility, and that kind of goes back to that like Vakajuranga kind of thing that I brought up. That's like, I'm not going to wait for them to be like, can you, go and knock on the health minister's door? Let's do it, right? 29. I know how to find these people. Yeah. And then I think Mark. Oh my God. Oh my God.
Ronnie, I have two questions. One of the questions is around, you mentioned stigma as a factor that promotes passive substance use, and that protection is something that's protected. Are there other factors you know of that separate substance use from passive substance use for queer youth in particular? And then the second one is around like ethics of disclosure. So if they disclose something really troubling, like what is your ability to intervene versus you have to intervention?
Oh, yes. That second question, I will answer that one first. In terms of like ethics of disclosure, we do have team protocols. So when you do qualitative research with queer youth, it's important that you have those in place. So we have around like suicidal ideation, we have that around like disclosures of like self-harm. And so we've developed those resources. So if we do hear it, we pause the interview and we say, are you okay? Are you in a good place? Do we want to continue? As a part of, for many of you who've done like the BREB, there's always that like, participation is optional. And the big thing for me is like, if you're not in a good place and you're talking about difficult things and I think that it's harming you, then, like I said in a lot of like the diary entries, I'm like, there will be more research. I'm not the first and the last person who's going to do this work. And so I'm not going to see you harmed because I need a thesis. And so I think those are some, so like it's important to really develop, and these are things like, so that's kind of when we think about the ethics of disclosure. And then we also talk about folks too, when we kind of intake them, we say like, oh God, what is it called? Duty to disclose. So if you do mention like aspects of like abuse that you've had as like a youth within a particular age range, then we have to stop. But there's always like a little bit of neutrality. I will not say that this is like a specific practice of the team, but there's also a lot of neutrality in terms of like deciding whether or not, like if someone is in a place of crisis, to connect them with carceral systems, and deciding like whether or not this is going to actually help them. And so those are just the kind of things that we take into consideration. And it is difficult, like in qualitative research, especially when we think about, I don't do ethnographic work, but a lot of my colleagues talk about the difficulty of being able to provide that support remotely as a result of the shift because of COVID-19. And like what you do when I pull up a diary entry and someone's like, I was feeling suicidal last week, and you're like, well shit. And we did develop policies around that, like the researcher will read the diary, will get back to you within 72 hours if there are concerns, and they'll reach out to you, and if they don't hear anything, then X, Y, and Z. So there's like clear steps that we took. It's not just like, oh no, this is not good, but like you have to, when you do qualitative research, and when you do qualitative research with populations that are facing a lot of difficulties, by virtue of systems of discrimination and shitty policies, you have to put in that work to ensure that you know how to navigate it, because it's not only just difficult for them, but also potentially traumatizing for you as the researcher. And sorry, what was your first question?
Yeah. Substance use is not always hazardous substance use, so like, what are protective factors against substance use becoming hazardous for queer youth in particular versus factors that promote hazardous substance use?
I think it's difficult when we talk about like problematic substance use with queer youth, because oftentimes when we talk about like gaps in care and the lack of support that exists like institutionally, in healthcare and stuff, that like oftentimes, as I mentioned, like substance use is often the best resource available to folks if you don't feel comfortable being out to your doctor, or drop-in clinics have been unsafe, or if you're a part of, if you're outside of VCH and you're in Fraser Health, or you're in Northern Health and other sort of health authorities where politics are different and where it's not safe to disclose that you're trans, or not safe to disclose that you're queer. Wait, what was I answering? Oh no, had a direction there. Oh yeah, harmful correlations. Oh, I'm so sorry. But this can be a conversation. Like, sorry, where did I miss? My apologies.
Oh, I'm just curious, like, yeah, we talked about connections
Oh.
and stigma is possible.
Yeah.
I'm just curious, like, these other
Protective factors.
literature.
Yeah. Oh yeah. I mean, protective factors, like oftentimes, as I mentioned, just like having community there, like oftentimes like having friends there to be like, okay, I'll use with you, or if we're gonna go to a party, like in my own experience, it's like, okay, I'm usually the one who's like, okay, I'll help you divvy out the substances, or whatever, or like, we have the Narcan kit, so like all the steps that and it's largely because we have to look after each other, or other queer folks have to look after each other, or folks a part of. That's why we have the Vancouver area network of drug users and all those other communities, because like healthcare, police, government, not going to do anything. And so I think some of those protective factors, whether it's always like we have to be careful how we frame it, because they're like we can look at resilience, but it's also demonstrative of like neglect. But is that helpful? So those are some of the ways. And like protective factor, just like feeling connected with community, having multiple individuals to go to as a result of like the shift to virtual means of interaction that you have like pre-existing community. And like, so that stuff in like parenting all. Oh, I didn't put it up there. Anyways. It's there, just abstractly, it's in the cave. Yeah, so hopefully that was helpful. Mark, you have a question?
Great to see you. I can say about that. You've had me in this room.
What?
Yeah. One of the candidates, great social scientists, and thinkers of big thought. Now, the only point I want to make, questioning is, you're doing qualitative research, and you're getting your data by getting people to write down. This is surely, generically, a big deal. Diary writing is not some sort of mutual activity, or even something that everyone does. Who thinks of diary like that these days? Some of you do, I don't. Michel Foucault started working up his theory of what he called the technology of the self. And established that none of the really important regimes of self-care, in certain traditions anyway, is this journaling or diary. That's certain aspects of my experience in life. Now, you could do this, of course, without having a friend in social science who doesn't know your child. So I'm curious, at some point you can brief your research subject on the value that they may discover in the process of thinking about it.
Yeah. So in the follow-up interviews, I did ask about sort of like their perceived like strengths and perceptions of like the diary entry process. And some folks mentioned that they really appreciated, as you sort of brought up with your example of Michel Foucault, kind of like the ability to think critically about things that they would otherwise. Many of the folks said they don't keep diaries themselves, and so this was an interesting exercise about like sitting down and just kind of examining their experiences with the crisis in many ways that they would just otherwise, externalize in different ways. And so I think that was one example that came up in terms of just like people thinking about how diary processes sort of work with them. I'm trying to think in terms of other sort of aspects. Oh, I think, well, not to draw this back to like implications, but I think just the approach of diary methods, and this is me kind of like shaping the question to something I want to answer, so apologies, Mark, sort of gave us a sort of unintentional finding around the fact that a lot of qualitative research that some teams do inevitably do not include or think about people's different needs when it comes to like accessing research spaces. So like a lot of this remote work, like diaries, whether they be written or remote, provide people to interact with research on their own terms from spaces that they feel comfortable doing so. And this is, I think, helpful in terms of just like, whereas previous to the pandemic, a lot of the research that I've done, and our team has recognized that this is something we should think about moving forward, has been in person, and it's required folks to kind of leave their own personal spaces and come to the university or come to particular sites to then talk about these experiences. And that kind of wraps up, because then that also introduces like power dynamics. What does it mean for like a young queer youth who's like 19 to come into the BC Center on substance use on Howe Street and take the elevator to the 4th floor and walk through like the curiously colored scheme of like, I don't know, like pastels, but like not friendly pastels. And so those are the other things. So yeah. 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 So yes, and I think it was really interesting to also see, and really, because especially when you just do like semi-structured, like one interview, that you get a very specific snapshot of a person where they are in that particular point in time. And sometimes they're not in a great place. And this is focusing a lot on my feelings about it, which, not always very relevant. But I think that longitudinal interaction over diary entry, bookended by intake and follow-up interviews, kind of also provide not only myself, but participants the sense of being like, oh, look, I was not doing great here, but then I've done better over the time. And so there was like different moments, or even like the little optional aspects for people who filled it out. When we talked about, they're like, oh yeah, it was nice that I don't know, watched Netflix with my sister, we found something. It was a hard week then. And so I think those are kind of aspects. But I don't want to tout this as like, oh yes, we will solve social inequities if we all just diary, because I'm not going to diary after this. I wasn't diarying before, and I don't think I will after. But it is nonetheless, I know, I'd rather not keep things on paper. Yeah, but no, I agree. It's a very interesting method that I would very much like to continue working with, and maybe be less of a hypocrite and actually engage with it myself. Yeah. Oh my gosh. Yeah. Oh, sorry. Yes.
So I'm not from Vancouver, and I have some sense of this question stems out of what I read maybe last year sometime around, I think, some members of the BC government either discussing or maybe this already passed decriminalizing drug use in some form. And I was wondering if you could give like a really quick layman summary of what you mean when you're speaking about the government's response to substance use. Is that like at least like very recently, and like especially because it's all tied up with like all the hospitals and healthcare things are mostly public here, right?
Yeah. Yeah. So some of the response, so it looked like different things. At like as I guess the public-facing, very like communications level, we've had John Horgan, for those of us who remember, I think was it last year, who made that really weird, if we're going to look at like narrative analysis and conversation analysis, around him being like, well, substance use is more of a choice, but COVID-19 is like not. And that like, that's an example of how we see like, that's like one example of government, response, where you see like, oh, okay, this indicates how this particular administration actually feels about people who use substances, and they think that like somehow substance use is still focused on the individual level and stuff. And then we also have like different interventions. So the BCCSU and a lot of, the BCCSU and a lot of other affiliated research organizations focus on like opioid agonist therapy and and all these other sort of medical-based approaches, pharmacological. Anyways, there's terms that I'm not pharmacotherapeutic that don't always work. And so that's another example where like, and that kind of goes back to my example around positionality, around like institutions deciding in sort of top-down fashion on like what kind of therapies will work in order to address addiction, and how people in the community, through work with ethnographers and qualitative researchers and organizations like WARS and Vandu, have said, well, we don't know if OITs always work. We need, heroin compassion clubs and all these other sort of things that are community-based solutions that look at like, well, we need consistent housing. We need more safer consumption sites with more expansive hours. We need safer smoking and inhalation sites, and we need this across the province. So like, it's like looking at, when we look at that wasn't concise at all. You asked for concise, but yeah.
Just to follow up, so when you say pharmacotherapeutic solutions, do you mean, for example, like the kits that they hand out?
Yeah.
Has there been issues? Because I remember hearing about this in some parts of the U.S. and on like This American Life, they were talking about those kits kind of had like a alternative, like kind of ended up being a problem because people would take them and then the chemical reaction would very aggressively bring you down, and it was such an uncomfortable physical response that it was enough to sort of trigger using behaviors in response to it. So it ended up kind of, and it also increases like sort of very high risk behaviors because of that. So I wonder, is that what you mean when you say pharmacotherapeutic? And also, I don't know if you
or like,
similar.
Or like, because there's like safer supply, so that I think kind of addressing like the naloxone. So some of the critiques around like the focus on naloxone initially have been like, it's focusing on like overdose, but it's not addressing the fact that there's a tainted drug supply. Right. And so when I think about therapeutics, so like it's kind of focusing on those things, or focusing on particular like, how we say, combinations of like medications. So like recently with Safe Supply, there's been some like provision around like dexedrine for folks who use stimulants and stuff. But again, there's a lack of research, and there's also just, I don't know, I'm still like learning about this myself, but I would very much say that like, so it looks like different things. It looks like, what sort of replacement therapies the government decides or policymaker decides are effective and will help folks versus like what is actually needed on the ground or what drug users and drug user advocates say is needed. And so like this is when I talk about like government reaction or government response, and so like that kind of like talking past each other or not listening, and so those are kind of the things that came up, and hopefully that was helpful.
Super.
Yeah. Okay. I think. Hopefully, stay tuned. Yeah. Thank you.